is a detailed explanation of pelvic inflammatory disease, PID. Unit 1, Introduction. Pelvic inflammatory disease, PID, is a polymicrobial infection of the female upper genital tract. It primarily affects sexually active women and can result in severe reproductive health complications such as infertility, ectopic pregnancy, and chronic pelvic pain. PID typically results from ascending infections, most commonly due to sexually transmitted infections, STIs, like Chlamydia trachomatis and Neisseria gonorrhoeae. Early detection and treatment are crucial to prevent long-term consequences. 2. Definition. Pelvic inflammatory disease, PID, is defined as an infection-induced inflammation of the female reproductive organs, including the uterus, endometritis, fallopian tubes, salpingitis, ovaries, ophiritis, and surrounding pelvic structures. The infection often ascends from the lower genital tract, vagina and cervix, to the upper genital tract, leading to widespread inflammation. 3. Etymology. Pelvic originates from Latin pelvis, meaning basin, referring to the bony structure at the base of the spine. Inflammatory, derived from Latin inflammatia, meaning a setting on fire, symbolizing the body's response to infection. Disease, from Old French disease, meaning lack of ease, denoting a pathological condition. 4. Epidemiology, affects approximately 1 in 8 women with a history of STIs. Around 1 million women are diagnosed annually in the U.S. Women aged 15 to 24 years are at the highest risk. PID can be subclinical, making true prevalence hard to estimate. It is more common in areas with limited access to sexual health education and services. 5 types. 1. Acute PID, rapid onset with severe symptoms such as pain and fever. 2. Chronic, long-standing inflammation with less intense but persistent symptoms. 3. Subclinical PID, asymptomatic or mildly symptomatic, often detected during infertility workup. 4. Recurrent, repeat episodes due to reinfection or inadequate treatment. 6. Causes. The most common causes are sexually transmitted infections, STI, Chlamydia trachomatis, Neisseria gonorrhoeae, polymicrobial infections involving anaerobes, e.g. Bacteroides pp., Mycoplasma genitalium, Gardnerella vaginalis, non-sexual routes, postpartum or post-abortion infections, intrauterine device insertion complications, pelvic surgeries. 7. Risk factors. Early onset of sexual activity, multiple sexual partners, history of PA or STIs, inconsistent condom use, recent IUD placement, douching alters vaginal flora, low socioeconomic status due to limited healthcare access. 8. Complications, infertility up to 20% after one episode, higher with repeated episodes. Ectopic pregnancy due to scarring and blockage of fallopian tubes, chronic pelvic pain, long-term pain from adhesions or nerve damage. Tubo-ovarian abscess, a localized pocket of pus that may require surgical intervention. Fitzhugh-Curtis syndrome, perihepatitis presenting with right upper quadrant pain. Sepsis, in rare severe cases, infection can spread systemically. 9. Pathophysiology. Pathogens ascend from the cervix to the uterus, fallopian tubes, and ovaries. 2. Inflammation leads to edema, exudate, and infiltration by immune cells. 3. Tissue damage. Epithelial lining of the fallopian tubes may be destroyed, impairing ciliary function. 4. Scar formation. Adhesions and scarring impair fertility and cause chronic pain. 5. Abscess formation. In advanced cases, accumulation of pus may occur. 10. Signs and symptoms. Lower abdominal pelvic pain, most common. Abnormal vaginal discharge, often purulent. Fever, 38.3 teeth. Chills, nausea and vomiting. Painful intercourse, dyspareunia. Painful urination, dysuria. Irregular menstrual bleeding. Cervical motion tenderness. Uterine or adnexal tenderness on bimanual exam. Diagnosis. Clinical criteria, CDC minimum criteria, lower abdominal pain, cervical motion tenderness, uterine or adnexal tenderness. Additional diagnostic tools. Laboratory tests. N8 for chlamydia and gonorrhea. Elevated WBC count, ESR or CRP. Imaging. Transvaginal ultrasound to identify abscesses. Laparoscopy. Gold standard for diagnosis, especially in atypical or severe cases. 12. Nursing diagnosis. Acute pain related to inflammatory process, risk for infection transmission related to unprotected sexual activity, anxiety related to diagnosis and possible infertility, knowledge deficit related to disease process and prevention, impaired tissue integrity related to inflammation and infection. 13. Medical management, antibiotic therapy, empirical broad spectrum, ceftriaxone 500 mg IM plus doxycycline 100 mg D for 14 days, metronidazole 500 mg BID for 14 days. Hospitalization indicated for severe illness, high fever, nausea, vomiting, pregnancy, tubo-ovarian abscess, no response to oral therapy. Surgical intervention for ruptured abscess or failure of medical therapy. 14. Nursing management. Assessment, monitor pain, vital signs, and vaginal discharge. Medication administration, ensure compliance with antibiotics. Patient education, importance of completing full antibiotic course, safe sex practices, partner notification and treatment. Supportive care, provide rest, hydration, and pain relief. Emotional support, address fears about fertility and relationships. 15. Treatment options, outpatient, oral antibiotics and follow-up within 48 to 72 hours. Inpatient, IV antibiotics, especially in severe cases or abscesses. Surgical, laparoscopic drainage or salpingectomy in complicated PID. Partner management, treat sexual partners to prevent reinfection. 16. Psychosocial interventions. 1. Health education, teaching about STIs, prevention, and reproductive health. 2. Sexual counseling, addressing concerns about sexual activity post-infection. 3. Psychological support, managing anxiety, depression, or fear of infertility. 4. Couples therapy, encouraging communication and joint decision-making about treatment and prevention. 5. Community support groups, peer-led groups for women with PID, infertility, or chronic pelvic pain. 17. Prevention, consistent condom use, limiting number of sexual partners, regular STI screenings, especially for sexually active women 25, prompt treatment of STIs and partner notification, avoid douching, educating adolescents and young adults about sexual health. Conclusion. Pelvic inflammatory disease is a preventable and manageable condition when diagnosed early. It remains a significant public health issue due to its impact on fertility and quality of life. Comprehensive care, encompassing early detection, appropriate antibiotics, patient education, and psychosocial support, is essential. Raising awareness about safe sex practices and STI screening plays a key role in reducing PID incidence. Thank you. Have a nice day.